Welcome everyone. Thank you for joining us today for this BHR ENT webinar supported by BHR CPN Training Hub. I'll just take you through some very basic general housekeeping just to make sure the session runs smoothly, but then I'll hand you over to Mr. Kumar, who will introduce you to our speaker for today. We have a presentation which will last around 40 minutes. And at the end of that 40 minutes or so, we'll have about 10 or 15 minutes for questions. Throughout the presentation, if you can make use of the chat function to pose your questions, it's possible that we won't. Sorry, I'm just muting someone. It's possible that we won't have time to answer all of the questions, so I want to make sure that we can capture every question, and I can then pose it to our speaker for offline response. If, however, you do want to pose your question directly, so to speak, at the end of the presentation, if you indicate by raising your hand through the function, I'll invite you to turn your video on and you can pose your question directly. We are recording the session today. We're recording it so we can upload it to the website so that either yourselves or your colleagues can access it at a later date, and we can just spread the reach of this event and make it as useful and impactful as possible. Obviously, if you want to remain anonymous in that recording, then again, do make sure you keep your video off. If everyone can keep their videos and their microphones off throughout the session, that will reduce distractions while the presentation is taking place. And in terms of making sure you have the clearest visual experience that you can I just ask everyone to make sure that they are on what we call speaker view. So if you hover your mouse over your screen, if it says speaker view at the top, if you click that, you'll be focused on the presentation taking place. If it says gallery view, then you're fine, you're in exactly the right place, you don't need to do anything. If you just have one big picture in the middle, one big video in the middle, then you're exactly the place. So that's all of the housekeeping I wanted to go through. I'll hand over to Mr. Kumar and invite him to introduce our guest speaker. And if you could unmute yourself when you speak, thank you.
Thanks, Paul. Thank you. Welcome, everyone. Thank you, Mr. Kadur, for agreeing to do our first talk. Thanks, Paul, for organizing and helping us out with the IT side of this event. And we hope to do this event every month, first Thursday. So we have Mr. Kadur today. He has been working with the BHR since 1997, and he has been clinical director for special services at BHR. His special interest is in head and neck, anti-skull base, thyroid surgery. Over to Mr. Kadur to take you through our two-way pathway. You can unmute yourself, Mr. Kadur.
Yes, I did. I'm just sharing the screen. Is this?
Yeah, it's coming up. Yes, we can see it.
Up. I just lost it. Sorry, guys.
We can see it.
No, I can't see it myself. Oh my goodness me. That's what expected.
And it worked so well in the rehearsal.
Yes. Is it okay?
Can't see it.
We cannot see the screen when you.
Can you see me?
Yeah, we can see you.
But not the screen, not the presentation.
No. So if you come out again and share, when you click on share screen once, it will ask you full screen or.
There you go.
Yes.
Yeah, yeah.
Perfect.
Is that okay? Well, at last, good afternoon, everybody. It's a pleasure to be with you this afternoon. Thanks very much, Mr. Kumar, and thanks very much, Paul and the organizer. I think it's a golden opportunity to start working together and sharing our experience and how can we improve our service for our patient. I've been asked to talk about the head and neck cancer pathway in the region. So why do we meet today? We're meeting to look at the current head and neck cancer service. We also looking how to improve the service and what are the challenges and the futures of the head and neck at HBRUT. Let me just start with some facts, basic fact about head and neck cancer. Head and neck cancer is rare. It's about 2 to 3% of the total body cancer, but it is heterogeneous. There's about 30 subsize in the head and neck. The incidence of head and neck in UK is about 11 per 100,000 population. That means we are diagnosing around 12,000 new cases in England and Wales. 2/3 of them are male and 1/3 are female. The cancer larynx is the most common in the head and neck. When I looked at the figure in the HBRT in the last 5 years, we made a diagnosis of nearly 19,000 cancer, 3% with head and neck, which is in line with the national figure. When you look at the survival for the head and neck, for the first year, the survival in the region of 80–85%. And then the survival, unfortunately, declines as time passes by. So you got a 5-year survival in the region of 60–65%, and in 10 years' time, around 50%. So the most important crucial time for post-treatment survey is the first couple of years, where this is where the residual and recurrence may occur. When you look at the mortality in the head and neck in UK, unfortunately, it's about 1/3 of the 12,000 diagnosed, 4,000 a year passed away, almost 11 every day. And the head and neck cancer is the 5th most common cause of cancer deaths in UK and represent 2% of cancer deaths. There are definitely some risk factors in the head and neck, including the age, as we're becoming an aging population. So the incidence of head and neck and cancer in general, head and neck in particular, increases. There's also some genetic risk, particularly for the thyroid, like the medullary thyroid carcinoma, the smoking, the alcohol, some of the occupation, which is not that common now. People working in the wood, they may be more at risk to develop sinonasal adenocarcinoma. Obviously, previous head and neck irradiation. And more importantly now, we are seeing a surge of the endemic HPV viral-related oropharyngeal carcinoma and HIV. A significant number of all these risk factors are preventable, and some of them even with vaccination like HPV in the future. Head and neck cancer in general divided into UAT, which is the upper air digestive tract, and the thyroid. And I'm going to focus about the UAT this afternoon for the presentation more than the thyroid. We can talk about in another time. Obviously, in the head and neck, we cannot talk without politics. So the politics of the head and neck and the cancer in this country started very early in the 2000, where the NHS cancer plan, and later on 2007 reform strategy, and the NICE produced document in 2004 and 8 and updated also in 15 that was mainly improving the outcome guidelines. And in the outcome guidelines document, they're talking about the cancer centers where the patients are treated, and network of cancer centers and cancer units working together. But very important, the referring streamline and the development of neck lump clinic. We also talked about the multidisciplinary team meeting and the supportive service and rehabilitation, and the introduction of the specialist nurse, cancer nurse specialist, CNS. And more important, all this must be underlined by audit and research. So this is where the 2-week pathway referral for urgent suspicious of cancer has been introduced. Why? For the simple reason, hoping that will be a faster track for urgent referral for suspected cancer. Subsequently, there will be early diagnosis and early treatment, and we know that will be signified and improving the outcome and improving the prognosis and the survival in 5 years' time. But the question is, does it work? They, in this document, introduce the 14, 31, and 62 rules by which the patient will be referred mainly from the GP referral. He or she must be seen within 2 weeks. That's why the term 2 weeks referral, and a specialist head and neck or target clinic, making the diagnosis hopefully within 31 days. And the case will be discussed in MDT, and the decision to treatment, and the treatment must start within 62 days. This is the pathway normal. Anything above that would be considered breach. When all this started, we used to have everything in-house. All the referral, the investigation, the treatment was done in the Queens, as well as the follow-up. But politics kicks in, so we're starting having Northeast London network and suggesting centralization of surgery. So the patient will be diagnosed at the Queens locally, making all the investigation, and then discussing a joint MDT. And now we do that, and we've been doing that for almost 8-7 years, a video link. And then the patient will be going to see the surgeon who's going to operate on him or her, either in the Royal London or Wilts Cross. And then they will have the surgery in London. And then for the last couple of years, this is even moved further west. And the surgery now is done in UCH. And the treatment, surgical treatment, will be done there. And then the patient will be followed back. Most of them will be seen locally in the Queens, but some of them will be continued to be followed up in the Royal London and Wilts Cross. So you can see how complex the pathway has become and complicated. And no wonder a lot of breaches and a lot of poor quality service has been provided, unfortunately. And this is why very important that we are having a significant number of breaches because of the complicated and prolonged the pathway. And it is very well known, if you don't take a decision to treat by the day 35, it is likely that you're going to have a breach for treatment by 62 days because of the lack of resources and the capacity, particularly when all the cancer has been centralized in UCL. That's in addition to the patient traveling from the very far east of London to the very far west of London, being there on their own without any friend visit or family visit, plus the financial implication of them traveling into London. And obviously the situation is worse in the COVID situation. We're all familiar with the symptoms which suggested that this is a head and neck and the patient should be referred. This is what we call red flag symptoms, and I'm going to talk about it later on in more details. And this is the form, which is the original one, and the new one, which is the banned London 2-week referral, is more complicated one, but all are tick boxes. I looked at the number of the 2-week referral at our trust for the last 5 years, and we have received 124,000 plus 618 2-week referral, 8% with head and neck, around 10,000 referral over 5 years. And when you look at our 2-week referral over the last 5 years, hovering around 2,000, 300, but it is on the increase, as we can see. So how effective is the 2-week referral in picking up head and neck cancer? In UK, there is around 100,000 2-week referral for suspected head and neck cancer. Out of them, around 10%, it varies from one unit to another unit. On average, around 9–10%. So for every patient you diagnose, you need to see around 11 or 12 patients. When I looked at our figures at the BHR, for the last 5 years, we made a diagnosis, newly diagnosed head and neck cancer, 617. Out of almost 10,000 2-week referrals. So the pickup rate is probably less than average national figure, which is around 6%. How effective is that? Some years ago, I looked at how effective is the guidelines for referral head and neck, and I wasn't also surprised. The pickup rate was in the region of 5–6%. That's 2007. And the situation hasn't moved or changed much, unfortunately. So as I said before, when you look at the 2-week head and neck cancer referral for the last years, it is on increase, and on average around 2,300–400. That is in addition to the upgrading from within the hospital, which in the region for 300–400 a year. So when you look at the number of head and neck, newly diagnosed head and neck cancer at our trust, from 2015 to 2019, on average, we have 110, 115 newly diagnosed head and neck cancer. That means the percentage of pickup over the last 5 years on average, again, was around 6%. Interestingly, when you look at the patient who diagnosed with cancer, 1/3 of them has been coming from the non-2-week referral pathway. This is in general in our trust, and not just the head and neck, all types of cancer. And when I looked at our figure for the head and neck, again, 36%, which is about 1 in 3 of newly diagnosed head and neck cancer, they have been referred through another pathway, not the 2-week pathway. So how can we improve our 2-week referral system to improve the pickup rate of head and neck cancer? This is a question for all of us. Maybe auditing the referral, and we have been doing that, and it's definitely a lot of room for improvement for the referral way, and maybe changing the form. The form may be just dated and very complex and a lot of irrelevant information. But this needs some national agreement rather than local one. Maybe using some what we call a risk assessment tool, which is being used in the bladder and the prostate. Maybe doing a telephone clinic triage so one can assess the referral and make a decision over the phone and triaging the 2-week referral. Also, the idea of having a consultant hotline advice, but obviously that needs more resources and more time, and time is money. So we'll be available for you 24/7 for any advice over the phone if necessarily. And also importantly is the education, like the seminar today. This is the first time we have been talking to each other for many, many months or possibly years. So talking about the risk assessment tool, some of the colleagues, Professor Barley and Mr. Mackenzie, Professor Barley from Royal Marsden and Mackenzie from Glasgow, and their teams, they looked at 10,000 2-week head and neck referral and having assessed stratification, risk assessment stratification, and invented head and neck cancer risk calculator. And that was a version 2, which was published in January this year. This is a tool to assess the risk of referral and looking at the patient demographic, the age, the gender, the smoking habit, the alcohol consumption, and the 12 red flag symptoms. It has a sensitivity of 85% picking up positive, but not very specific, around 78%. And the positive predictive value also is low, around 21%. But more importantly, the negative predictive value is 98.6. That means they have a cutoff percentage of 2.1% and less. The chance of this being cancer is 1.4%. This is very good. And this is the risk calculators, all web-based, very easy to use. Unfortunately, I can't connect it to the computer, show you how to use it, but it's just a Dropbox. You fill in the age, the gender, male or female, the symptom, unintentionally weight loss, yes or no, the smoking, whether a currently smoker or ex-smoker or never smoked, alcohol, the hoarseness, whether intermittent, persistent, sore throat, being unilateral, bilateral, intermittent, persistent, same dysphagia, neck lump, odynophagia, ulcer, oral swelling, otalgia or earache, stridor, any skin lesion, and feeling of something in the throat, what we call faucet. So it's very easy to use. Unfortunately, I can't connect it to the line. And then they have 3 categories of risk. A high risk, when you score more than 7.1%, a moderate risk, more than 2.2, and low risk, less than 2.2. I took an audit of the 2-week cancer referral back in May, and I discovered almost 60% of the referral was of low risk. So that means unlikely to have cancer. And 1/4 is a high risk, which he should have been referred, and also a moderate risk around 19%, which should be seen as urgent. And when I looked at the same time, the patient was diagnosed with cancer in the same period of my patient, and find that 90% of them were high risk and around 13–12% was moderate risk. So I think the risk stratification is a very useful tool to use. Let me talk about the red flag head and neck symptoms. That's mainly the hoarseness, neck lump, sore throat, rhinophagia. We just go one by one. Hoarseness, patient, particularly male with a persistent hoarseness, persistent, not on and off, not intermittent. This is likely to be some organic pathology, either affecting the movement, as we see in the video here with the vocal cord palsy, and the patient will have, my voice has been very soft and a breezy voice. On the other hand, when you see a patient with some tumor, the video is a bit slow, affecting the vocal cord, the hoarseness will be hoarse. My voice has been hoarse for the last 3-4 weeks. I can't talk now, and now it's very painful. I'm starting not being able to swallow. This is really very significant. And you can see when you had the patient and diagnosed is a very extensive laryngeal tumor with some dysphagia. The patient cannot breathe, cannot swallow. You can see a lot of food debris and candidiasis and fixation of the hemilarynx. So hoarseness is one of the most significant symptoms in the head and neck, and the patient must be referred. But I mean the persistent hoarseness, not the patient has been having change of voice, deep voice, on and off, is very tired in the morning, and feel very dry, or by the end of the day, I'm losing my voice because he or she is a teacher and so on. So you really have to analyze the symptoms. Again, rhinophagia is very important, and painful swallowing, sore throat, particularly when the sore throat is unilateral and persistent. This is very significant. Rather than people having intermittent sore throat, discomfort, feeling something in the throat, that is likely to be reflux-related globus. But when it is unilateral, you can see it's a tonsil and base of tongue tumor on the left-hand side, very obvious. So a unilateral persistent sore throat for more than 3 weeks, not responding to any antibiotic, and the patient is in really pain, and some of them, they will have referred otalgia and taking regular paracetamol and starting food getting stuck in the throat. All this are very, very serious, and the patient must be referred through the 2-week symptom. The other symptoms is the neck lump. Again, neck lump is very worrying. And before going to the neck lump, just briefly, the neck, the most important is the sternomastoid. In the front of it is the anterior triangle, and posterior to it is the posterior triangle. And I'm not going to entertain you about the subdivision of the triangle, but it's very important to know where is the lump and where is the swelling. When you look at the swelling in adult, majority of them, 80% are malignant and 20% are benign. This is in contrast to a pediatric or the children, the other way around. The majority of them are benign and the minority, 20%, are malignant. Then when you look at the lump in the neck, in the front of the neck, this could be a dermoid cyst, it could be lymph node, and in the midline, pretracheal, thyroglossal cyst, thyroid nodule, or thyroid isthmus nodule, or lymph node. But more serious is the swelling in the lateral neck. You can see it could be in the parotid, it could be submandibular gland. Parotid swelling, again, 80% are benign and 20% will be malignant. On the other hand, the submandibular swelling, about 50% malignant and 50% are benign. And then you can get very common is the thyroid in midline, to the right, to the left, or on both sides, and it moves up and down in early stage when patients swallow or talk. And more importantly, you get the lymph node, which along the jugular vein, Occasionally you get cystic lesion, like a branchial cyst, and sometimes you get other swelling like lipoma, schwannoma, sebaceous cyst. But I just warn you about lymph gland. In particular, this is very, very serious. And we are seeing a surge of HPV-related oropharyngeal carcinoma, and the majority of them, they are not a high-risk patient. We have seen them in female, non-smoker, non-drinker, and quite often present with a cystic swelling in the side of the neck like a branchial cyst. This is a trap, and it's becoming almost endemic because of change of social practice and oral sex. Neck lump should be seen in one-stop clinic. We call it neck lump clinic, by a head and neck surgeon, in working together with a cytologist, radiologist, and CNS. And I have been doing this head and neck clinic since 2005 in January, for almost 16 years, Tuesday morning. And I have also a session attached to me in the afternoon for ultrasound FNA. And we have been doing this for many years, as I said. And most of the patient will be referred from the 2-week pathway. The patient will be seen at the neck lump clinic. We'll have a full history taking and full head and neck examination and flexible endoscopy and ultrasound guided FNA if and when necessarily. I looked early on different occasions. The last audit I did, and we presented in our clinical governors, I think some 6 months ago, 2008, the whole year. And the majority of the patients were female. And you can see the practice here, that reflects my practice for the thyroid, half of the neck lump with the thyroid related. And then you get another significant number, the lymph node, and most of them, they are benign, but malignant, and metastasis is very important. But still a significant number, maybe 25%, is inappropriate referral. And then you get a small percentage of the salivary gland tumor. Then we, another point to improve the backup is using the telemedicine and the telephone triage, as we have been doing. And the ENT UK, which is our head and neck ENT association, during the COVID has recommended remote triaging of urgent suspected head and neck cancer referral during COVID pandemic situation. And we have been doing the telephone clinic since April. And obviously it has got some advantage, being safe, the convenient, the triage, cost effectiveness, but also has some disadvantage, the communication issues, the documentation, the technical support, the training, the time consuming, change of culture, and may also have a medical legal issues implication. I've done some audit of my telephone, 2-week telephone clinic, which I've been doing since mid of April. And I looked at the figure back in May, primarily to how appropriate and how effective is the telephone clinic and head and neck 2-week referral during COVID. And the secondary objective to look at the type of patient, investigation, diagnosis, and outcome. Sorry. And that was a prospective audit, which was presented. And again, you can see 61% were female. That is very similar to the neck lump clinic. And the age group, mainly middle and elderly people. The ethnicity, again, 2/3 of them were local. But it's importantly that the DNA patient not replying is very low because they're very convenient. And I've been talking to some patients who are on holiday, a couple of patients, one in Spain, one in Italy, which is fantastic, of course. But more seriously, is about 45% of the patient after first and second telephone consultation has been discharged. So we're saving a lot of resources here and avoiding face-to-face. And when I looked at the patient has been referred for face-to-face, that was about 11% of the referral, which is very good. Also, the pickup for cancer was 7%. And when you look at our head and neck cancer over the last 5 years, hovering around 6%. So we haven't missed any cancer patient. When you look at the investigation, I think it's a significant number, maybe more than half, didn't need any investigation, just analyzing the system, the symptoms, and assuring them. But more importantly, I'm starting using barium swallow more than my normal practice. And that is because a significant number having globus and reflux related symptoms. And you can see the provisional diagnosis of the rest. And this is very common for patients having reflux-related symptom or laryngeal pharyngeal reflux. You can see the edema on interathenoid and the postcricoid area. Patient quite often complaining of faucet, what we feel, feeling something stuck in the throat, lump-like sensation, intermittent croaky voice from time to time. Another one, you can see the edema because of the acid refluxing, quite often silent reflux. So be aware, this is very, very common, and I think should be managed in the community very easy. So what are the challenges we are facing? We're chasing, obviously, the COVID-19. We all know that the history has been called before Christ and after Christ. But in medicine, I think the medicine has become before and after Corona, BC and EC. This is the biggest challenge we are facing nowadays. And we are also awaiting for, hopefully not, a second wave of COVID, which will be absolute disaster. We are also facing challenge on the testing, particularly for the medical staff and the patient. Meeting targets, and you can see here, there is a drop of the 2 week in London, and then it's picked up. And now I think the number is more than average, because this is the only pathway available for you to transfer the patient and refer the patient. And subsequently, the waiting list has increased, with the resources obviously has to be increased. We also the challenge with the education and the training. And we forgot about the psychological impact on pandemic on patient and even on the medical staff. So what is the future? The future hopefully is bright and pink, but I can't tell what is the future. But I suspect we will continue with the COVID for the next, hopefully not long, but I suspect a year or two, possibly more. So we'll continue to have a green pathway, which is a COVID-free. I doubt it very much will be something called the COVID-free, and the other yellow, which is the COVID managed or COVID cure. We will continue to have a remote telephone, maybe a video clinic will be the default for the pathway. We'll continue to use the risk assessment tool like the head and neck cancer risk calculator to minimize the face-to-face consultation. We are relying more on the image-based diagnosis because of the no contact. So there is increase of the demand and request for imaging, and that with the limited resources. We'll continue to do our virtual MDT, and we are looking at the post-treatment surveillance and improving that and changing that according to the current circumstances. But it's very important that it should be underlined and underpinned by updated clinical guidance, because at the moment we're still using dated clinical practice guidelines, and obviously that potentially have some medical legal implication. The surgery will continue to be according to the priority from the Royal College of Surgeons, priority 1A, which should be done within emergency 24 hours. priority 1B within 72 hours, and then priority 2, which should be done within a month, and most of the cancer will fall into that category. Priority 3, which would be done in less than 3 months, and most of the thyroid cancer will be into that category. And then priority 4 for routine cases. We'll continue to have the preoperative self-isolation for 3 days, not 2 weeks anymore. We're having the testing 48 to 72 hours before, and the patient will have surgery in a COVID-free site using a full BB by all the medical staff, and discharge it early, and then needing to have post-operative 2-week self-isolation and followed up remotely. And then come to the final slide, which is a single-site surgery. We have seen the movement of surgery from the local, the Queens, where all the facilities are available, and the surgery has been done effectively and safely for years, and then moved to the Royal London for more political reason, and for even political reason moved to UCL. And with the COVID and the local lockdown, this is feasible. Should the surgery come back to where it belongs, where we have all the facilities available, even we have the radiotherapy. You would be interested to know that UCL, they don't have a fresh frozen section facilities. So the specimen will be taken by courier across the town to parts to have the histology, while the patient on the table waiting for the result. We have everything at house, the chemotherapy, radiotherapy, the surgery, the intensive care, and above all, the personal expertise. Finally, I would like to acknowledge all my colleagues, Mr. Kumar, our lead clinician, and Mr. Weiss, a consultant head and neck with interest in rhinoplasty and rhinology. Mr. Veer, he's a consultant ENT with interest in sleep study and obstructive sleep apnea, and my colleague, Mr. Jain, who is interested in the head and neck and helping me a lot and taking over. And our princess, Jabin, is also doing head and neck. And Mr. Amro, who is also interested with Veer developing the obstructive sleep apnea and sleep study. And it goes without say that all this hard work done over the years has been supported by my all staff, particularly our CNS sister, Karen Gunnar. She's been with me for almost 20 years, although she's much, much younger than me. And obviously the support of Dr. Aukati from the pathology, Raid Kelani, Sanjeev, our nursing staff, the secretaries, and everybody. And finally, thank you very much for listening, and I'm quite happy to answer any of your questions. Thank you.
Thank you, Mr. Gadoor. So, Paul, are you there?
Yes, yes, I can hear you. I'm just sipping some water. I'm feeling very dry. I've been having a clinic in the morning and talking now, and another clinic after that.
So, Mr. Gadoor,
yes,
you mentioned about this, the Excel sheet which we are using, the triage pathway. What is your opinion, like if we roll this out into community and use it as a screening tool? We follow the same process, but use it as an audit and look, because it is looking to be very impressive, like 98%. So essentially we can use the resources better if we use this triage pathway.
Yeah, I totally agree with you. I mean, you have seen the figure for the 2-week referral. Our figure represents 6%, which simply means we are seeing around 15, 16 patients to pick up one case. Okay, and nationally, the figure hovering around 9%. When people starting using the risk calculator, the pickup rate jumped to around 21%. So there is more selection. It will give, obviously, at the moment it's used by specialists in the hospital, but I think I'm hoping it will be used by our colleague in the community, but it needs some training. So we can categorize the patient into low risk, which could be referred as routine, a moderate risk, which would be referred as urgent, and the high risk, which would be referred as 2 weeks. That would release some of the resources for the 2 weeks, because the current situation, any patient referred as a 2 week, and we've seen a lot of inappropriate referral, and I'll give you an example, because of this, the guidelines is a symptom based. A unilateral nasal obstruction for more than 3 weeks. I've got a broken nose, deviated nasal septum, definitely for more than 3 weeks. So I am entitled to have an urgent referral. What we need to do is to qualify the symptoms and analyze the symptom, not a matter of tick box exercise. So I suspect the use of the risk calculator was very useful in improving, and I hope the current version 2 will improve too. My figure only in a small audit, and I have looked at the figure for the last 3 months, and I have a figure of almost 400, and in the process of publishing this very soon. And I believe there is a national audit also looking at how effective that risk calculator, which was endorsed by our ENT UK society.
We have a question on the chat. Is the referral criteria for hoarseness is 3 weeks, and you mentioned 6 weeks at the beginning of presentation.
Yes, yes, there's a very good observant. I deliberately left this. This was the initial guidelines for NICE 2004. It gives you a clue about my age. This has been changed later on 2015 to more than 3 weeks. But initially for the NICE guideline was 6 weeks. I think we have to qualify the hoarseness here. And I emphasize persistent hoarseness. It means it hasn't improved. On the contrary, it got worse. But patient for 6 months, I'm losing my voice by the end of the day. My voice gets tired when I talk. When I'm dry, I'm a teacher and I'm a singer and cannot get to the high note. All this will be classified as hoarseness and unfortunately referred as 2 weeks. That is where the problem is. But on the other hand, a gentleman or even a lady, a smoker, drinker, 40, 50, and my voice, I lost my voice for the last 3 weeks and it's not getting better. This is the patient must be referred. And on that note also, I will question very much the value of chest X-ray. What we worried about the chest X-ray for hoarseness is the left vocal cord palsy, bronchogenic carcinoma. What is the backup on chest X-ray for bronchogenic carcinoma? It's less than 50%. It's waste of time. So this patient must have endoscopy, assess if there's a vocal cord palsy, they will have a scan, not a chest X-ray.
Yeah, there is a comment, excellent presentation of red flags. So one more question, Mr. Guru.
Yes.
Will it be right to say then, the impression is that if we use the triage calculator and our virtual clinics, because of the COVID, better, then we can target the cancer target the early pickup of cancer better, so we can use the resources better. So we should continue to provide our services in a similar pattern, maybe 30% face-to-face and rest virtual. Will you agree with that?
I totally agree with you. But I think the current problem from my point of view, the medical legal aspect of medicine, clinicians here are worried about missing a diagnosis and get sued. And I think with the current circumstances, unprecedented, the normal law doesn't apply. That is my opinion. Obviously, you have to have a legal advice on that. And this is what I said, we have to update the clinical guidelines. Otherwise, the whole service and the system will collapse. We cannot cope. The only pathway available for our colleague in the community now is either A&E or the 2-week pathway. So we are seeing a surge of unnecessarily 2-week pathway. Patient having unilateral hearing loss, say, for example. Yes, it is a medical emergency, but not 2-week pathway. That's for just a simple example. And the globus pharyngeus is a big chunk of there. And I deliberately didn't talk about the thyroid. I would love to talk about thyroid another time, because this is another minefield. Patients seeing our colleague in the community and having neck ache, and they send for ultrasound, oops, thyroid nodule, 4 millimeter, reported by sonographer, everybody upgrading, U3, which is indeterminate. You need further investigation because it's suspicious of cancer. The patient get worried and the referral. And we know that 90% or more of the thyroid in ladies in the 40s and 50s are benign, and they don't need any invasive investigation. But that is the current situation. A lot of inappropriate referral.
Can you scroll back to the slide where it gives the website for the tool calculator? Can you go back to the slide? Just, so that people can take picture of that and note.
Yes.
Some slides back. Sorry.
Not this one. Oh, dear me.
That's fine.
A lot of slides.
Yeah,
this one.
Next one. Yeah,
this one.
Yeah.
It's a web-based. Unfortunately, when you connect it, you go off the Zoom. It's a very easy Dropbox. Click age, and then it calculates your risk, and the risk will be at the end. So the patient, the age, the gender, male or female, the smoking habit, the smoking, the alcohol consumption, everything, just take box. At the end, it gives you a calculation of the risk.
Right. Yeah, thank you. Any more questions? All right. I'll thank Sab and Jyoti as well for organizing this. And I'm just waiting if Amlesh, our director, is there online. I can't see him. Amlesh, if you are online, can you unmute yourself? Right. In that case, thank you, Mr. Gadur. And the next webinar will be on 7th of, let me see, no, 7th, not 7th, 8th, Thursday, first Thursday of October, same time. And there will be a feedback form emailed to everyone. You can complete and send it back. That will be really helpful. Any feedback to improve these talks will be useful.
Mr. Kumar, can I just say your colleague has just rejoined, so if you want to invite him.
Yeah, so we have Amlesh, he is our division director. He would like to say a few words, please.
Thanks, Gaurav. Can you hear me?
Yeah, yes.
Thank you. Thanks, Gaurav, and thanks everyone for joining us. And it is great to have all of you, along with Gaurav, to engage in this way in which we, secondary care and primary care, can engage in the COVID times. I think things are moving quite at a big pace, both by way of NEL, NHS London, and also locally. And unless we can engage with each other and see each other, we will miss what we're doing. And especially from the NHS London, and as well as from the strategic side of how we deal with things, things seems to be moving. Every day seems to be something different. So it's great to have this, and this will be not the last. I'm sure this will be first among the many. Not only for Gaurav, and we'll try to engage with different other specialties on a similar manner as well. I think Gaurav has started a fantastic journey, and hopefully we'll all be a part of it through the next months and years. Thanks.
Thanks, Amlish. Thank you. All right, thanks, Paul. Thank you. Thank you, Mr. Kadur.
No problem at all.
Thank you very much.
There is one question in the chat about certificate attendance. We'll be sending out some feedback forms to everyone who's attended. If we can have those back, and we'll and your certificates will be generated after that.
Paul, can you answer this as well?
Yes.
Yeah, about the recording.
So I'll send out the website link to everyone and to everyone who's registered, really, for those who couldn't make it as well. So you'll be able to access it directly from that.
Yeah. So we plan to record all the sessions going forward as well, so that people can access it, rewind and revisit the presentation. Yeah.
Excellent. Okay. So if there are no other questions.
Thank you, everyone.
Thank you very much, everyone, for joining, and see you soon.
Thank you very much.
Thank you.
Thank you. That was really good. I didn't understand most of it, obviously, but even I found it really interesting.
No, thanks very much, Paul. Honestly, it wasn't medicine; it's just politics, and but it went fine. Thank you very much for your help.
There's lots of really good feedback in the chats.
Good.
Thanks for the presentation. Extremely useful presentation. Yeah, lots of things like that. So it definitely landed well, very well received. So thank you very much for your time. Really do appreciate it.
Thank you. Thank you. See you again. Take care.
I'm sure we'll be speaking soon. Thank you very much. Take care. Bye.
Take care.